Hello, everyone, and welcome to our module on systolic and diastolic heart failure. Shown on the screen are echocardiogram images from two patients of mine with heart failure. In both images, you can see the left ventricle of the patient in short axis as it contracts. The image on the left is from a patient with systolic heart failure. The ejection fraction of this patient is severely reduced. It may be hard to appreciate this if you're not used to looking at echocardiograms, but the amount of squeezing of that left ventricle on the left side of the screen is markedly reduced. That patient's left ventricular ejection fraction is about 10 to 15%. On the right side of the screen is an image from a patient with diastolic heart failure. The ejection fraction of the ventricle on the right side of the screen is normal at about 55 to 65%. Now, even though these two hearts look totally different, they both are from patients who have signs and symptoms of heart failure. Both of these patients have many of the signs and symptoms I discuss in the video on heart failure basics, things like pulmonary edema, and elevated jugular venous pressure, and dyspnea and lower extremity edema. Those symptoms are happening for very different reasons, and that's why we have two forms of heart failure. Systolic heart failure is characterized by a reduced ejection fraction as shown on the left, and diastolic heart failure is characterized by a normal ejection fraction as shown on the right. So as I mentioned on the last slide, patients with both systolic and diastolic heart failure can have the same congestive symptoms. They can have dyspnea and orthopnea and paroxysmal nocturnal dyspnea. They can have rales on physical examination, elevated jugular venous pressure, and pitting edema. The one exception are what's called low-flow symptoms. These only occur in patients with systolic heart failure and only when the left ventricular ejection fraction is severely reduced. These are signs that result from a very low cardiac output. They're things like cool extremities, cachexia, and confusion. You will only see these in end-stage systolic heart failure. You'll read in your textbooks about something called a dilated cardiomyopathy, so let's talk about what this term means. Dilated cardiomyopathy refers to systolic heart failure with left ventricular cavity dilation. When there is a reduced ejection fraction in systolic heart failure, the left ventricle often goes through a process called eccentric hypertrophy that leads to cavity dilation. And when you have the combination of a reduced ejection fraction and a dilated cavity, that's called a dilated cardiomyopathy. The reason eccentric hypertrophy occurs is as a response to volume overload. When there's chronic retention of fluid in the left ventricular cavity, it will become dilated, and a process called eccentric hypertrophy will occur. Eccentric hypertrophy gets its name because the myocytes are growing in size. That's why it's called hypertrophy, but they are growing longer, not thicker. This is because sarcomeres are being added in series. If you look at the bottom of the screen on the left side, I've drawn a normal left ventricle, and you can see a normal sarcomere here. In a patient with eccentric hypertrophy, the left ventricular cavity dilates and sarcomeres are added in series. This makes the myocytes longer, and that's why the cavity becomes dilated. There are bigger myocytes here compared to normal, but they are longer. The walls aren't any thicker compared to normal. It's not that they're getting thicker, it's that they're getting more stretched out and longer, and that's what happens in eccentric hypertrophy. In contrast to dilated cardiomyopathy and eccentric hypertrophy, there is another pathologic process that can occur in the left ventricle called concentric hypertrophy. This occurs in response to pressure overload. If the pressures in the left ventricle are severely elevated for a long period of time, in other words, if you have chronically, markedly elevated pressures in the left ventricle, this can lead to concentric hypertrophy. This sometimes occurs in the setting of severe untreated hypertension or aortic stenosis. In this case, the myocytes become thicker, not longer, and that's why it's called concentric hypertrophy in contrast to eccentric hypertrophy. This results in a decrease in compliance. The ventricle becomes stiff, and for that reason, this form of hypertrophy is often seen in diastolic heart failure. We'll talk more about this in a minute. So at the bottom left side of the screen, once again, is my own drawing of a normal left ventricle with a normal myocyte. In concentric hypertrophy, the cavity size actually shrinks and the walls become thicker. The reason the walls become thicker is because there's an increased myocyte size, but in this case, that's because sarcomeres are being added in parallel, not in series. This makes the walls thicker and the myocytes thicker instead of making them longer, as occurs in eccentric hypertrophy and dilated cardiomyopathy. Shown on the screen are pressure volume loops for a patient with systolic heart failure on the left and diastolic heart failure on the right. In both examples, the blue pressure volume loop is a normal patient, and the red pressure volume loop is a patient with either systolic or diastolic heart failure. And we're going to go through these two pressure volume loops in detail in the next few slides because they contain all the fine details of these two disorders that you're going to be asked about on the Step 1 exam. The primary problem in systolic heart failure is a fall in contractility. That causes the pressure volume loop to switch from the blue one up here to the red one. In diastolic heart failure, on the other hand, the primary problem is a fall in LV compliance or lusitropy. Basically, the ventricle is stiff and it has problems filling with blood. That results in a change from the blue loop to the red loop shown on the right side of the screen, and we'll go through both of these in the next few slides. So let's talk about those two pressure volume loops in more detail. In systolic heart failure, just like in all forms of heart failure, systolic and diastolic, there's a decrease in the cardiac output. However, the problem in systolic heart failure is in systole. That's how it gets its name. In systolic heart failure, there's a fall in contractility, and therefore the left ventricle can't get the blood out. If you look at this pressure volume loop on the right, I talk about in the video on pressure volume loops how changes in contractility shift the end systolic pressure volume relationship. That's this dotted line right here. And what happens when there's a fall in contractility is that the line shifts to the right, as I've shown in this picture here. That changes the pressure volume loop from the blue one shown on the screen to the red one. So let's talk about what's different between the blue and the red pressure volume loop. Well, first of all, the red pressure volume loop has a smaller stroke volume, and that should make sense to you. There's a fall in cardiac output, so there must be a fall in stroke volume. Stroke volume is represented by the width of the pressure volume loop, and you should be able to easily appreciate that the width of the red pressure volume loop is narrower than the blue one. Now, stroke volume is equal to the end diastolic volume minus the end systolic volume. And in systolic heart failure, there's a big rise in the end systolic volume. That's the volume that is left at the end of systole. In other words, the volume that's left after the ventricle has squeezed. And because there's a fall in contractility, there's more blood left behind when the ventricle squeezes. That leads to a rise in the end systolic volume. There's also a rise in the end diastolic volume. That's because the end diastolic volume is determined by the end systolic volume plus the venous return. And since we have a higher end systolic volume, when you add the venous return to that, you get a higher end diastolic volume. And you can see both of these changes in going from the blue to the red pressure volume loop on the right. This point right here is the end systolic volume of the normal heart. This point right here is the end systolic volume of the heart with systolic heart failure. Notice that it is a higher volume. This point right here is the end diastolic volume in the normal heart, and this is the end diastolic volume in the heart with heart failure. It has also moved to the right. And notice that when we move to the right in terms of the end diastolic volume, we also move slightly higher. In other words, this point here is a little bit higher than this point here. That means that on the y-axis, which represents pressure, we have also gone upwards slightly, and therefore in systolic heart failure, you get a rise in the LVEDP. And in the video on heart failure basics, I talk about how in all forms of heart failure, you have a rise in LVEDP, and that is true here. And you can actually see that in this change in pressure volume loop on the right, going from the blue loop to the red loop. There's also a characteristic change in the Frank-Starling curve in systolic heart failure. I talk about Frank-Starling curves in detail in another module, but by way of review, a Frank-Starling curve shows the relationship between preload or left ventricular end diastolic volume on the x-axis and stroke volume on the y-axis. A normal curve looks something like this blue line I've shown here, and when there is a fall in contractility, as occurs in systolic heart failure, the curve shifts to the right. What this means is that for any given preload, you will get a lower stroke volume in the heart with systolic heart failure compared to normal, and that should make sense to you. There's been a fall in contractility, so for any given volume of blood loaded up into the left ventricle, you get less stroke volume when there is systolic heart failure. Now let's talk about diastolic heart failure. In diastolic heart failure, just like in systolic heart failure, there's a decrease in cardiac output. However, in diastolic heart failure, the problem is in diastole. There's been a fall in left ventricular compliance and lusitropy. The ventricle has become stiff, and therefore it cannot relax and fill with blood. There's a problem getting blood into the left ventricular chamber. In the video on pressure volume loops, I talked about how a decrease in compliance shifts the left ventricular and diastolic pressure volume relationship, which is this dotted line right here. It shifts it to the left like this, and that makes the pressure volume loop change from the blue loop, which is normal, to the red loop, which is what's seen in diastolic heart failure. So let's talk about the consequences of those changes. First of all, in diastolic heart failure, there is a small decrease in stroke volume. This is because there's a slight decrease in the end diastolic volume due to decreased filling. And this is an important distinction between diastolic heart failure and systolic heart failure. In systolic heart failure, we talked about how the end diastolic volume goes up because the chamber is congested. In diastolic heart failure, blood can't get in, so there is a small decrease in end diastolic volume. And you can see that here. This is the end diastolic volume. Normally, there's a small decrease in the loop from diastolic heart failure. The major consequence, however, of diastolic heart failure really has nothing to do with volumes. It's got to do with pressures. The major problem in diastolic heart failure is that there is a significant rise in the left ventricular end diastolic pressure because the ventricle has become stiff. I've cleared away my ink to show you this. So at the end of diastole in the normal blue pressure volume loop, this is the left ventricular pressure on the y-axis. When the curve shifts to the left like this, it results in a dramatic increase in the left ventricular pressure at the end of diastole. And that's the major issue in diastolic heart failure. It's not got to do with volumes. It has to do with the pressure going up in the chamber, and that leads to the signs and symptoms of heart failure. For the remainder of this module, I will talk about specific causes of systolic and diastolic heart failure. So in the case of systolic heart failure, the most common cause is myocardial infarction or coronary artery disease. In these cases, the myocytes are replaced by scar tissue after an infarction. This leads to what's known as an ischemic cardiomyopathy, where the left ventricular ejection fraction is reduced. There are, however, many causes of what's known as a non-ischemic cardiomyopathy. About 50% of non-ischemic cardiomyopathies are idiopathic, but there are many other causes, such as those listed on the screen here, and we'll talk about these later in this video. About half of cases of heart failure are systolic, and the other half are diastolic. Unfortunately, in the case of diastolic, the exact cause is largely unknown. Many patients with diastolic heart failure have concentric hypertrophy, like I discussed before, and there are many associated conditions, even though we don't understand what exactly causes diastolic heart failure. So, for example, diastolic heart failure is associated with advanced age, diabetes, and hypertension. All of these things are often present in patients who have this condition. And one thing that's confusing at the student level is that diastolic heart failure goes by many different terms. It's sometimes called heart failure with preserved ejection fraction. Some people like to call it HFpEF, and it's also sometimes called diastolic dysfunction. I'll go through some of the causes of non-ischemic cardiomyopathy. These are all causes of systolic heart failure. The first one is viral. A non-ischemic cardiomyopathy can follow a viral infection, especially an upper respiratory infection. There are many associated viruses, although Coxsackie virus is one of the classic ones. But this type of cardiomyopathy has also been described following infection with influenza, adenovirus, and many other types of viruses. It's believed that the virus enters the myocytes and causes myocarditis, which leads to the cardiomyopathy. Now, the myocarditis phase often goes undiagnosed, so patients don't know they have it until they develop systolic heart failure. And there's no specific therapy directed against the virus. You just treat the patient for systolic heart failure. Peripartum cardiomyopathy is a form of non-ischemic cardiomyopathy that occurs late in pregnancy, usually in the third trimester or early postpartum. The exact cause is unknown, and it's likely got a multifactorial etiology. And the major problem with this cardiomyopathy is that for women who develop this condition, in many cases, they have to be advised to avoid future pregnancies because the risk of a recurrent cardiomyopathy and worsening symptoms is significant. Chemotherapy can lead to a non-ischemic cardiomyopathy. This usually occurs after treatment with anthracyclines. These drugs are anti-tumor antibiotics that I discuss in detail in the hematology section. Specifically, doxorubicin and daunorubicin are the classic drugs to cause a non-ischemic chemotherapy-related cardiomyopathy. There are rare familial cases of non-ischemic cardiomyopathy that are caused by gene mutations. These are often the result of gene mutations in genes that code for sarcomere proteins, like beta-myosin heavy chain or alpha-myosin heavy chain or troponin. Many of these familial cardiomyopathies are autosomal dominant, although X-linked and autosomal recessive cases have also been described. Some patients with arrhythmias like atrial fibrillation have no symptoms from the arrhythmia and are unaware they have the condition. And if they have a fast heart rate that goes on for weeks or months, this can lead to a cardiomyopathy called a tachycardia-mediated cardiomyopathy. Basically, the constant rapid heart rate over the course of weeks or months leads to a depression of LV systolic function. And the nice thing about this cardiomyopathy is that it's reversible if you treat the arrhythmia and slow the heart rate down. Another form of non-ischemic cardiomyopathy is called Takotsubo cardiomyopathy. It's also called apical ballooning cardiomyopathy. This is a stress-induced cardiomyopathy. It's very interesting. This often occurs after severe emotional distress. For example, I've seen this happen to patients after the death of a loved one. I saw it happen to one patient when her dog died. The severe emotional stress, for reasons we don't completely understand, lead to a depressed ejection fraction in a small subset of patients. These patients present to the hospital with a markedly reduced left ventricular ejection fraction and signs and symptoms of heart failure. They usually have elevated cardiac biomarkers like CK, MB, and troponin. They also have EKG changes. This will look just like an anterior myocardial infarction. However, when these patients have an angiogram, they have no coronary disease. And the good news is that these cardiomyopathies usually resolve in 4 to 6 weeks. So many of these patients have a very unfortunate emotional distress that leads to heart failure and a hospitalization. But luckily, a few weeks later, their left ventricular function recovers. The reason it's called takotsubo and apical ballooning is because of the peculiar pattern of depressed left ventricular function. If you look at this image at the bottom of the screen here, what happens in this cardiomyopathy is that the base of the left ventricle contracts normally. That's this thick black portion here. But the apex, which is this portion right here, does not contract at all. That leads to a pattern in echocardiogram where the apex of the heart balloons outward because it's not thickening or contracting when the base contracts vigorously. That's why it's called apical ballooning. It gets the name takotsubo because this kind of cardiomyopathy is common in Japan. And in Japan, there is an octopus trap called a takotsubo, which has a funny shape that looks just like this. And that's what the ventricle looks like when the apex balloons out and the base contracts. So therefore, it's gotten the name takotsubo cardiomyopathy. Alcohol is a well-described cause of systolic heart failure. The condition is called an alcoholic cardiomyopathy. It's usually seen among alcoholics. Chronic consumption can damage the heart. This is believed to occur due to toxic metabolites, although the pathophysiology is incompletely understood. And this can recover if people stop drinking. So one thing I do in my own practice when I meet someone with a new onset cardiomyopathy is ask them how much alcohol they consume. I'll finish with this slide and describe a rare form of heart failure called high output heart failure. This is really distinct from systolic and diastolic heart failure. This type of heart failure occurs when the heart is in overdrive, such as in a case of severe anemia or severe thyroid disease. It's also been described in cases of thiamine or B1 vitamin deficiency. It's also sometimes been described in patients who have AV fistulas, and therefore their heart is pumping vigorously to try and pump blood into the arterial system, which is then being drained by a fistula quickly into the venous system. The exact mechanism of this form of heart failure is unclear. It may be related to decreased left ventricular filling time, but the defining characteristic is a high cardiac output. I told you earlier that in all forms of heart failure there is a low cardiac output, but I actually lied. There is this rare exception, which is high output heart failure, where if you measure the cardiac output, it will be high, but nevertheless the patient has heart failure symptoms despite the absence of a low output. So the hallmark of this cardiomyopathy is a high cardiac output, yet symptoms of heart failure like high jugular venous pressure and pulmonary edema, and you're only going to see it in strange scenarios like these ones I've described on the screen here. And that concludes our video on systolic and diastolic heart failure.